Good afternoon, everyone. Today we have a seminar on the topic theories of schizophrenia. So, starting from the earliest, initially there was an issue in classifying psychotic illnesses. Heterogeneity exists in different psychotic illnesses with nearly as much heterogeneity within the diagnosis as between two diagnoses. So, psychosis is a general medical condition which can present in a variety of ways. But schizophrenia is a particular group of symptoms, a particular syndrome. So, the concept of psychosis included a large number of disorders earlier. It included even with something with medical comorbidities like general paralysis, syphilitic insanity, any cause that would cause delirium was included in psychosis earlier. But schizophrenia is different from that. So, first of all, Emil Kraepelin described a disease. He observed a large number of clinical cases exhibiting a common pattern of course, which ultimately resulted in severe cognitive and behavioral decline. He called it dementia precox. So he recognized a different psychotic disorder within psychosis as a symptom. So Eugene Bleuler first coined the term schizophrenia for this particular disease. Kurt Snyder, in his classification, later classified the first rank symptoms, 11 first rank symptoms to describe schizophrenia. So we all know the symptoms of thought withdrawal, thought insertion, thought broadcasting, delusional perceptions, and experiencing feelings and actions as made or influenced by external agents. The At that point of time, it was a diagnostic criteria that presence of one of these symptoms in the absence of intoxication, brain injury, or clear effective illness was taken as sufficient to make a diagnosis of schizophrenia. But still, even today, we continue to diagnose schizophrenia based solely on the phenomenology. We don't have any investigations, we don't have any imaging to diagnose schizophrenia because we don't know the exact cause. So to find out what is the exact cause of schizophrenia, various theories have been proposed. So the first theory was made from an observation that the most powerful risk factor for schizophrenia is having a relative affected with the disorder. So that led to the genetic theory of schizophrenia. So the studies have shown that the lifetime risk for schizophrenia increases 1% from 1% in general population. And if there is a first degree relative, then this risk increases to 10%. And if there are two first degree relative, two parents have schizophrenia, then the risk increases to 50% in in the child. So this is a graph which shows which shows the incidence. So in general population with no relative of with schizophrenia, the incidence is 1%. As the relatives get closer, in like first cousins, uncles and aunts, nephew and nieces, the percentage of incidence increases. So in third degree relatives, it is around 12.5% because they share about one third of the genome. Second degree relatives, they share about half of the genome, that's 25%. First degree relatives, 50%. And in identical twins, we can see that incidence is as much as 48%, which the twins will share the same genome. So, so two studies were done, adoption studies were done in which Heston and Denny conducted a study in which 5 out of 47 children of mothers who were adopted away within a few days of their birth later developed schizophrenia, compared with none of the 50 adoptees with the no family history of schizophrenia. So this led to the belief that it was not. So this theory, no, this study, what they did was they take 47 children, their mothers had schizophrenia. The children were adopted immediately after birth. So they shared the genes, but they did not live in that household, did not have those environmental factors that were going on in that household. The children grew up somewhere else, away from the family, away from the mother. They had that genome. 5 out of 47 later developed schizophrenia. On the other hand, they took a control group. They took 50 adopted children with no family history of schizophrenia. None of them developed schizophrenia. This proves the point that there is some kind of genetic predisposition to schizophrenia. There is a first degree relative with schizophrenia. Then another study was grown-up children of normal individuals who who were placed with an adoptive parent who had schizophrenia. So the child is genetically normal from a normal family. He is adopted into a family where the parents have schizophrenia. There was no significant increased risk in that for the disorder. Even after family studies showed that genetic predisposition is there for schizophrenia, then they had twin studies in which they uh, found that the incidence of schizophrenia in monozygotic twins was 46% and in dizygotic twins was 14%. The evidence reflects that when monozygotic twins have share all of their genes and dizygotic twins share only half of their genes, The further evidence of the effect of heredity comes from the evidence that the concordance rate in 12 pairs of monozygotic twins who were reared apart was 58%. So even if the monozygotic twins, they separated at birth and they grow up away from each other, there is still 58% incidence, incidence in both of them. But this also led to uh, uh, another finding that even in monozygotic twins, they share the same genome, the exact same genome, and still the incidence was only 46%. So there is a possibility that you can share the exact same genome as your identical twin, still not develop schizophrenia, not develop the symptoms of schizophrenia. So there must be some factors, uh, some other factors other than genetics that lead to the development of the full symptomatic disorder. Further evidence and support comes from study which shows that offspring of identical twins as well as co-twins of the individual with schizophrenia carry a risk of disorder similar to that of the offspring of the affected twin. So two identical twins, both of them have children. One of them has developed schizophrenia, one of them has not developed schizophrenia. Yet their children have the exact same predispositions to schizophrenia. So genetically they carry the risk with them, but it is not necessary that every one of them develops schizophrenia. So So the inference from this is that predisposition is transmitted, always transmitted, but it may or may not be expressed as schizophrenia as a full symptomatic disorder. So if we say that schizophrenia follows a simple Mendelian inheritance, like we used to study in 12 standards, कि recessive है, एक gene recessive है, एक dominant है. If that was the case, then this would not have happened. फिर तो अगर dominant gene होती वो express कर जाती से और monozygotic twins दोनों में same ही genes होती तो दोनों में symptomatic disorder होता. But so that is definitely not the case. So people with schizophrenia, but also if there was such a gene that led to schizophrenia and it was dominant, so people would have been uh, filtered out from the gene pool because every subsequent generation they have a less tendency to reproduce. They have less tendency to find a partner to get married. So over period of time, the disease would have been filtered out of the gene pool, but still the disease is prevalent. The most of the what the model developed was that it is not a single gene or a single allele. It is most commonly a polygenic model, which states that the number of genes of small effect are involved. Sometimes some of the genes are affected, sometimes some other genes are affected. The support from this model comes from the fact that the risk to an individual increases with the number of affected relatives. So in a whole extended family, there is always history of schizophrenia somewhere or the other. So, so maybe not in the direct relative, there is no any history, but sometimes people say, किसी के मामा को schizophrenia है और मामा के बच्चे schizophrenia है, but still the person develops schizophrenia, even if first, second, third generation relative. But the risk is always there. One of the earlier slides, I also had a table which even third degree relatives, there is still risk more than the general population. 3% third degree relative में था, general population 1% था. So some amount of risk is there. The major culprit genes, two of the genes have been found were yes. So two of the major culprits that have been found out are neuroguline and this bending gene. The association between schizophrenia and a multi-marker haplotype, a pattern of DNA within the gene of neuroguline 1 on chromosome 8p2122. It was found in two studies in Iceland and Scottish population. It was present in patients with schizophrenia consistently in a large sample size. And association was also found between single nucleotide polymorphism and multi-marker haplotypes. So this binding gene is also has been found a culprit gene located at chromosome 6p22.3. So another phenomena that we see in the genes is the disc one, the disrupted in schizophrenia one. This is not a gene, but this is a translocation. This is not found in normal population, but in some people there is a linkage in translocation between 111 and Q42, Q14.3. Two portions of different chromosomes swap portions with each other, and they form this disrupted in schizophrenia one, the disc one. So this has an increased tendency to cause psychotic features. So it is not only seen in schizophrenia, but in any psychotic illness, broad phenotype, which consists of schizophrenia, bipolar disorder, recurrent depression. So this can be found in any one of them. The translocation is called a disruption of a gene. That is why it is called disruption in schizophrenia. So this may be a susceptibility gene for both schizophrenia as well as bipolar disorder. So another gene, it is not directly found, it has not directly been found a culprit, but based on the mechanism of action, the catecholamine O methyl transferase, the COMT, it has a role in dopamine metabolism, especially in the prefrontal cortex. A missense mutation generates valine to methionine substitution in codon 158. So it produces an unstable enzyme, and unstable COMT enzyme, which causes a decreased degradation of dopamine. So naturally, that causes an increase in dopamine and more psychotic features. So direct studies have not shown any evidence, but biochemical evidence is there. So this is the reaction. The COMT enzyme, catechol O methyl transferase, causes the degradation of active catecholamines, dopamine, norepinephrine, and epinephrine to inactive metabolite, which gets excreted. Any abnormality in the COMT enzyme increases the levels of these neurotransmitters and in turn causes increased psychosis. This is a table from CTP which summarizes the genes, major culprit genes. So after that, another theory was there, a neurodevelopmental theory of schizophrenia. The genetic studies have shown that hereditary factors play a role. But as we saw in monozygotic twins, even they share the same gene code, same family upbringing, but yet one of them may not develop. There is still 48% chance, 52% chances there that identical twin will still not develop schizophrenia. So some environmental factors need to be present to lead a person to cause a fully symptomatic illness. So also 1% incidence in general population was still there. किसी कोई फैमिली हिस्ट्री नहीं है, कोई जेनेटिक प्रीडिस्पोजिशन नहीं है, बट स्टिल 1% चांसेस देयर कि schizophrenia symptomatic तब भी हो गया था. So there might be some environmental factor which has caused that particular person to develop schizophrenia. The association has been found with right from the beginning with pre and perinatal complications. So the studies have shown patients suffering from schizophrenia are more likely to have a history of pre and perinatal complications than the healthy subjects from the general population. Possible that some excess obstructive combinations may have may be due to some pre-existing abnormality. A mother with schizophrenia may not come for ANC follow-ups. So there may be bad hygiene that might lead to any obstetric abnormality, any viral infections. So that might be reason that could have caused such studies could have caused false results in such studies. So, but also children who were subject to cerebral hypoxia at or before birth show an excess of abnormalities on MRI scans of minor neurological signs and cognitive and behavioral problems. So it is a monozygotic twins. Now, a study of monozygotic twins once again is quoted where both the twins had same genes. One of them developed schizophrenia, other one did not. The one who developed schizophrenia had larger lateral ventricles, smaller hippocampi than his twin who did not develop schizophrenia. In this MRI, we can see that this particular MRI is of the twin who had schizophrenia with larger lateral ventricles, and this MRI is of the twin who was fine and smaller lateral ventricles. So one of the studies showed that people who were born in late winter and spring are more likely than others to develop schizophrenia. So one of the hypotheses behind this was that during the first trimester of the gestation, the respiratory viral infections such as influenza occur in autumn. So maternal viral infection from rubella or influenza might have played a in first trimester might have played a role to develop schizophrenia in adulthood. There are social and geographical factors. So there is a 40% greater incidence in men than women. So in 1939, a study showed that an excess of individuals with schizophrenia was found in the deprived inner city areas, that is the poor areas. And the low socioeconomic class has a higher incidence of schizophrenia than the upper socioeconomic class. This has been consistently seen across the countries. But one of the reasons could be a theory called social drift. So the people with genetic predisposition to schizophrenia, over a period of time, they have gone down the socioeconomic class because they are less likely to hold an occupation, less likely to interact with other socioeconomic classes in an appropriate way. So over a period of time, they have not developed those families. They continue to carry the gene and have gotten poor over time. So that might be the reason that more incidences seen in low socioeconomic class. Also, that being born and brought up in poverty increases the risk factors like poor ANC compliance, more risk of infections. There is also an increased incidence in urban areas. A Swedish research found 1.65 times more incidence in urban areas, and another study reported births in urban areas of Holland carried twice the risk of schizophrenia of births in a rural area. It has been accepted that the incidence is higher amongst those brought up in urban areas, and that the larger the town, the longer the individual has lived in the city, that increases the risk. Immigration is one of the major risk factors that we study very regularly in schizophrenia. That migrants are an increased risk for schizophrenia. A notable example has come from a study, very famous study, ASOP study, in African Caribbeans residing in the United Kingdom who show a markedly higher risk of schizophrenia than their white-born British counterparts. This is from people from West Indies who have migrated to United Kingdom. They have shown an increase in incidence. So, and there was a control group of the same population who were stayed back in the West Indies. They did not come to United Kingdom. And there was the decreased risk. So, if genetic factor was the only factor, then there should have been an equal risk in both the populations. This was the ASOP study of the three English cities, and that demonstrated ninefold increase in incidence of schizophrenia among African Caribbeans and sixfold among those of African origin. Also, in the localities when the migrants shifted, and they were a minority within their own ethnic groups, like multiple minorities are living in an area, and that particular ethnic group is a minority. Even within that minority, they were at a further increased risk. So once again could be poor developmental disadvantage like maternal nutrition, poor obstetric care. Also, one of the possibilities that input forward is a paranoid reaction to the uh, social disadvantage that they have in a new country. Any discrimination that they might be facing, any racism they might be facing, that could have caused a paranoid reaction and increase in incidence. So anyone who was predisposed earlier. Significant life events can cause an increase in relapse of schizophrenia. There is an evidence that families who exhibit high expressed emotions can provide an environment which increases the risk of relapse in patients with schizophrenia. But once again, that can be explained by the fact that a person who has schizophrenia, he elicits more expressed emotions from the family. So anyone in the family who has a patient with a chronic psychotic illness, the family will obviously be a little bit more distressed than anyone else. So that could be a correlation. So it has been seen that substance abuse is more prevalent, illicit substance more prevalent in patients with schizophrenia than in the general population. The estimated prevalence of substance abuse in individuals with schizophrenia is of 20 to 60% and is higher than the controls. Cannabis Cannabis is a cumulative causal factor in cases of schizophrenia. Like the word was used in the CTP was tip the scales in individuals who might otherwise have some predisposition to the disorder. The cannabis use might just cause a symptomatic disorder. But we see cannabis one of the most commonly used drugs in the world. Still, a vast majority of people who use cannabis do not develop schizophrenia, and also many cases of schizophrenia are simply explained by genetic factors, other factors, and cannabis is not the cause. So we cannot say the cannabis is a cause for schizophrenia, but it certainly is a population attributable factor. So we see that schizophrenia patients with an early age of onset of psychosis are more likely than those with late onset of psychosis to have a history of exposure to obstructive complications. So if there are obstructive complications, so it is more likely the person will develop psychosis at an earlier age. Then if there is no obstructive complication, the person will develop it at a later age. Those who showed childhood a deficit such as low IQ also tend to have an early onset. And schizophrenia patients who abuse cannabis have been shown to have an earlier onset than who do not. So this was a study of age at onset and cognition in schizophrenia. The conclusion was that individuals with youth onset schizophrenia have severe cognitive defects, and those with late onset schizophrenia have relatively preserved cognitive functions. So cognitive effect is directly related to how much we can say that frontal lobe development was there when the symptoms started. So after that, in the 1960s, we had a neurobiological theory, which was mainly started by the dopamine hypothesis of schizophrenia. It proposes that symptoms of schizophrenia result from dopaminergic overactivity, whether due to excess dopamine or to an elevated sensitivity to it, maybe because of the increased number of dopamine receptors. Not in every case, we cannot find out that there is an increase in dopamine. So the genetic predisposition is that that particular person, the gene, the inheritance that he might be carrying is actually the increased number of dopamine receptors that might causing an increased sensitivity to the same dopamine. So later on, when the imaging developed and we had the functional MRI, so there is a strong evidence that presynaptic dopamine abnormality is there, with several studies showing elevated dopamine synthesis release and higher dopamine receptor occupancy in the striatum. In addition, excessive dopamine function associated with acute psychosis. There is also increasing evidence that deficiencies in dopamine transmission, especially in dorsolateral prefrontal cortex and genetically influenced, might underlie the working memory and allied cognitive deficits that occur in the disorder. So, dopamine dysfunction in different parts, like in the frontal lobe, can cause positive symptoms. It can cause the cognitive symptoms. In the substantia nigra, might cause the other physical symptoms. So, NMD receptor, there is also the N-methyl D-aspartate also plays a role. So, so it was saying that phencyclidine and other non-competitive antagonists of the NMDA produce a psychosis which resembles schizophrenia. So sometimes phencyclidine used as a recreational drug, so people develop psychotic symptom, which is very closely resembles schizophrenia. So it was a hypothesis put forward that NMDA receptor might be involved somewhere. So it is still a hypothesis. Some no functional MRI evidence is there for NMDA receptor, but sometimes drugs that enhance NMDA receptor activity have shown some benefit effects on positive and negative symptoms of schizophrenia. Serotonin is also involved. It was suggested initially because of uh, the hallucinogenic LSD, lysergic acid diethylamide, also had a psychotic symptom with its abuse. So LSD's the main function was is a 5-HT antagonist, a serotonin agonist. So because of its serotonin agonism activity, it was proposed that serotonin increase in serotonin might also cause a psychotic symptom. There is lowered 5-HT2A receptor expression in the frontal cortex schizophrenia and a blunted neuroendocrine response to 5-HT2 agonists. The high affinity for receptor may contribute to the profile of an atypical compared to typical antipsychotics. Typical antipsychotics mostly act on the dopamine receptors, but atypical antipsychotics, that is why they also have a some mood stabilizing effect because they involve both dopamine as well as serotonin receptor. And with clozapine, as you see, it is a significant activity of serotonin receptor and the comparatively less activity of dopamine receptor. That is why it also explains the mechanism of action of clozapine, the why it causes less extrapyramidal side effects but still contributes to a decrease in psychosis. Other than neurotransmitter, cerebral blood flow in schizophrenia has been studied using PET scan to measure regional cerebral flow and glucose utilization, and even in the functional MRI. So hypofrontality has been found, a decrease in the activity of frontal lobe is seen in many cases, but it is still not a consistent finding. So an effort was put forward to find out specific areas that might be the causal factor for schizophrenia. The relationship between superior temporal gyrus metabolic activity and auditory hallucination has been reported, and sometimes has been lateralized to the left hemisphere, but it is still not a consistent finding. And cognitive dysmetry is a finding in which deficits in activity in circuit involving the cerebral cortex, thalamus, and cerebellum are the key feature and the underlying memory difficulties of schizophrenia. So, evoked potentials have been measured. The P300 component is reduced, and delayed response to auditory and visual stimuli are indicative of impaired sensory processing. There is a high rate of eye movement abnormalities in schizophrenia, especially affecting smooth pursuit tracking and suggestive of impairment in neural pathways also. There is also differences in cortical signal to noise ratio in EEG and suggestive of an impairment of cortical information processing. But many of these studies, the functional MRIs, the MRIs, and the EEG studies that have been done, at that point in time, the patient is never in an acute phase or a patient is not fully psychotic. He is always in remission. That is why he's cooperative for such a study, for a long study. So most of them have been treated for antipsychotic drugs for some time. The findings are always open. These findings are neurobiological findings criticism that they may have been caused due to antipsychotic medication. Typical antipsychotics also produce enlargement of synaptic structural alteration in basal ganglia, caudate putam, and globus pallidus that might have caused a false positive in these studies. And chronic administration of haloperidol or olanzapine at therapeutic levels can lead to decreased brain volume, which might have caused that finding of hypofrontality that we have seen in cerebral blood flow. So thank you. My references were mostly from Oxford textbook and some tables from the CTP. Then based on the causes, first of all, then like in if there is any family history, the closer the relative is, like we saw in that table, if there's a Is he a sibling? Is he a parent? First degree, second degree, or third degree relative. The closer the relative is, the worse the prognosis is. The farther the relative is, that causes a better prognosis. The earlier age of onset has a poorer prognosis later on because of the it causes a more severe cognitive dysfunction. Later the age of prognosis can cause a later the age of onset of the psychosis can cause a can give a better prognosis. Because of cannabis can cause a poor prognosis. It can yes.